All right, so as promised, I'm going to just talk about the skin, head, and neck exam. You may see a puppy running around in the background. My apologies, but she is uncontrollable. All right, so most of these images that you see are right from Bates. Some, particularly the abnormals, are from the New England Journal. We'll start with the skin, hair, and nails. Just a couple of points. I'm only going to go through the interesting things. There are two kinds of sweat glands. One is the eccrine glands that are widely distributed, and they are the ones that send out sweat in order to cool our bodies, right? So my wife always teases me that I'm the only person whose legs sweat. I don't know if that's true. I think everybody's do, right? She claims hers don't. I don't know. But it keeps me cool, right? So it's worth it. So those are the ones that are over most of your body. And then we have the apocrine glands that are in the groin and the axilla. Those are stimulated by emotional stress, like when I'm teaching people smarter than me, like you. So those are the ones that that we all know about, and that's why we have right guard. For the health history, we want to find out about certain symptoms that may indicate bigger problems. One of those things is hair loss, right? Not a huge deal, but certainly it could indicate fungal infections, for one thing. It could indicate other integumentary problems, like, for instance, peripheral arterial disease. When there's severe blockages in the lower extremities, you have less hair distribution on the legs. So those are some things to keep in mind. Rashes, of course, are there's a gazillion different rashes, lots of different things for us to take into account there. And then moles. Just so happens that I just arrived home from the plastic surgeon with my son because he has moles that he doesn't like. It was kind of funny. He's 15. He says, I got these 2 moles. I don't want them anymore. I want to get rid of them. So we get there, and the plastic surgeon says, so, we can cut them out. He goes, wait, cut them out? She goes, well, how did you think I was going to do it? So don't have a 15-year-old son. All right. That's my take-home message from that. Talk to the patient about any changes in skin or hair, any moles that have changed size, shape, regularity. We'll talk about those things to be on the lookout for. I'm nervous. I don't know where she is. Come here. Go lay down. Any new moles, that's also a concern. Health promotion and counseling can be worked into the history and physical as well. So make sure that you use your time wisely, and don't make it artificial. Make it sort of work for the right thing. You don't want to talk about, breast self-exam and pap smears when you're doing a skin check, but you'll figure it out. The important thing that I didn't see anybody do on their video is to make sure that you have the patient in a gown. I don't know why you didn't have them in a gown. Oh, you don't have gowns. Okay, that makes sense. So make sure that you have access to look at everything, right? Every single square inch of their skin. And then you need good light. So natural light from a window, perfect. Because that is more natural and your eye sees things correctly. Artificial light, particularly fluorescent light, not as good. So we want to take note of color and make sure that we're looking for hypopigmented areas, hyperpigmented areas, which can be moles or freckles or such. Look for cyanosis. Carotidemic, which is what you get, sometimes young kids get from eating too much beta carotene, right? And then, of course, jaundice. And the best place to look for jaundice typically is the sclera. No, just kidding, not the sclera. The conjunctiva, right? You knew that, though. All right. Lesions, we want to note things about the lesions so that we can describe them, and hopefully that description will help people to identify them in the future. So you want to look at the location, how these lesions are distributed, whether there's a particular pattern to that distribution. Look at the shape and pattern of the individual lesions themselves. And then you want to look at the type of lesion and give it a name. Is it a macule, papule, whatever? And then, of course, the color. That's also important. New skin lesions that you haven't seen before, you should certainly look up. Get a nicely illustrated dermatology book that's appropriate for your level. Hopefully you start with, using Bates at the beginning would be fine. But while you're in clinical practice, you're going to see so many different things that you'll quickly graduate to needing a real dermatology book. And then make sure that you use that dermatology book to your advantage so that you actually learn this stuff, right? Over time, you'll learn to do good skin exams. So you'll inspect and palpate hair quality distribution. Look at the nails. There's tons of good information that we can get from the nails. I'll show you an example of that in the slides that I have. Again, skin lesions, we already looked at this, so we'll just move on. So these are the things that you need to know. Make sure that you know the definition of a macule. That is a flat lesion that's up to 1 centimeter. If it's over a centimeter, then it's a patch, right? Same deal, just different sizes. Papules and plaques are superficial raised lesions. So a papule, again, up to 1 centimeter, plaque greater than 1 centimeter. Wheals, by the way, you may see wheals in patients with allergic reactions, for instance. Urticaria, you'll see wheals, and those are very characteristic. We'll see some of those later. So nodules then are deep lesions. We talked about flat lesions raised lesions that are superficial. That's papules and plaques. But the deep ones are nodules if they're up to 0.5 centimeter, and they're cysts if they are fluid filled. If you can express something from them, whether it's pus or other fluid or what have you, that's a cyst then. Okay. There are fluid filled lesions, vesicles up to 1 centimeter. Bulla are greater than 1 centimeter. Some of the common abnormalities that you'll see are things like burrows, and that's like a tunneling inside the skin that you can see from certain organisms like mites, for instance, from scabies. And then scaling. I think we all know what scaling looks like. It's that real thin, flaky, just exfoliated skin that comes off. Sounds gross, right? Crusting is the dried residue that comes out of the skin. So the essentially plasma is really what it is. If that exudate or the transudate comes out of the skin and dries there, that is the crust. And then lichenification is visible and palpable thickening of the skin and roughening of the skin with increased visibility of the normal skin furrows. All right, so there's a picture of it here. You can see the little lines across there. Those are the normal skin furrows. Scarring we can see in a couple of different ways. We can see just normal scarring. That is easy to recognize. A hypertrophied scar like this, where you get just a little more thickness to it, is commonly seen. Particularly the darker skin that people have, the more you have hypertrophied scarring. And then also keloids. And keloid formation, this is someone's ear actually, it's hard to tell what it is, but this is a keloid on the lower pinna of the ear that sometimes develops, and it's just an exaggerated healing response. Again, blacks tend to be more likely to form keloids than others. This is, anybody know? I think I have the, there we go. So this is just a big hypertrophied scar that is actually has gone past the hypertrophy stage. This definitely meets the standard of a keloid, and that keloid happened right along this gentleman's incision. He had a big thoracotomy incision there, it looks like. Other secondary lesions, we look at erosions, and these don't scar, but they have loss of that superficial epidermis. And we see that in oral lesions like canker sores and things like that. I think everybody's had this before. I certainly have a lot of it with this puppy of ours. These excoriated lesions on my skin, they're just scratches. That's essentially what it is. So like cat scratches, for instance. Fissures. How many people have had a fissure on dry toes? Ugh, it's the worst. I have this one area on one of my toes that gets fissures all the time if I don't take care of it, especially in the summer when I'm running around without shoes and socks on. So they are often found where skin comes together. It's worse on dry skin, and sometimes people have that problem on their dry hands in the winter time. Ulcerations are deeper loss of epidermis than what we saw here. These erosions are just real superficial, but the ulcers are much, much deeper. This happens to be a venous stasis ulcer. All right, so some important vascular lesions for you to see here. These are, she hasn't done that before. These are spider angiomas, and those are characteristic lesion that we see. These are spider veins. I'm sure you've seen spider veins before. Then we have spider angiomas. So this is a venous process. This is an arterial. They're all sort of at the capillary level process. Hattie. But those are spider angiomas. And then, of course, we have petechiae and purpura. The thing to keep in mind about petechiae is that they don't blanch. So when you push on them, they don't blanch. Same with purpura. They don't blanch. So that's a very good indicator that what you're looking at is actually petechiae or purpura, as opposed to some other superficial lesion or a rash of some sort. Petechiae and purpura are they're bad news. They don't mean anything good ever. There's lots of different places that it can happen. Sometimes it indicates that you have DIC, right? That's the time that we worry about it in the hospital most. But it can also be seen. You can get those little petechial lesions. I see them in the summertime with patients who are overweight and they have excess, they have trouble getting the blood returned back to their heart because they have big bellies, right? And so that obstruction that they have in the vena cava impedes the return of blood flow to the heart, and this is one of the things that leads to venous insufficiency, right? And that venous insufficiency can increase the pressures in the veins and in the capillaries, and sometimes those capillaries just burst open, and you see this. So I don't know, it was 7 years ago. I was at the National Boy Scout Jamboree in West Virginia. I was on the medical staff there, and I had a bunch of people come in noticing this petechial rash on their lower extremities, and that's exactly what it was. It was what I call acute venous insufficiency, right? So when we see that dark pigmentation over a long period of time, that is chronic venous insufficiency, but this is sort of the acute phase of it, you could think. Hattie, what are you doing back there? Other abnormal lesions to keep an eye on are keratosis. Look out for skin cancer. You know about all that stuff, right? So here's some other images to look at. This is Seborrheic Keratosis. We also refer to it as Seb-K, right? Seb-K is just easier to say. That's the way the cool people say it. But this has a waxy consistency. You can scrape at it and you can get a surface of the keratization off if you just scrape it with your fingernail a little bit. Again, it has a waxy consistency to it. Completely harmless, but associated with aging. And it was probably 10 years ago that I first noticed some Seb-Ks on my scalp here, and it was devastating because I'm old and whatever. I guess it beats the alternative, right? Now that should be separate and not confused with actinic keratosis. This is a different process. This is not as benign, and I forget what all the specifics are about actinic keratosis, but I remember that this is something that typically needs some medication for. You'll learn more about that, right? So this is a nevus. This is a large, so nevi very often have hair growing out of them, and that's a bad sign. When you have a hairy nevus, that is a bad sign, particularly when you see these on the feet. They have a tendency to turn into something bad, so they should typically be removed and evaluated by derm or whoever. Well, have derm do it, right? Or plastics. Skin cancers. Remember, basal cell is the most common type of skin cancer. It's typically shiny and translucent, and they are very slow to grow, and there's no urgency usually to getting them off, but you don't want to wait until they cover such a large area, and it's hard to cover that area with just pulling the margins together. So it's important that they get the attention that they deserve. Squamous cell carcinoma has about 16% of the cancers. They can metastasize, so you want to be vigilant and quick to take care of them. And then, of course, melanoma, which is the most feared of all the skin cancers, comprises about 4%. But that's a very serious problem. The risk factors for melanoma are, they spell out HARMM, right? So H for history of previous melanoma, A for age over 50, R for regular dermatologist absent. No, sorry. Yeah, that's right. R for regular dermatologist absent. I don't even know what that means. What does that mean? I guess you haven't seen a dermatologist regularly. M for mole changing and M for male gender. Other risk factors for melanoma are listed here. I'll let you pause and take a look at that. And then the ABCDE that we heard about in class or in lab last night. These are some examples of skin cancers that have been seen. This top one is basal cell. This is squamous cell carcinoma. These on the right side are melanomas. These are very characteristic of melanomas that we are concerned with. This actually happens to be a melanoma as well. Now this one is it's not a spreading or metastatic melanoma, and I don't understand all the distinctions of these things, but when you see a discoloration, a darkly pigmented discoloration, you should be very concerned that it could be melanoma, whether it's in the eye, whether it's in the toenail, whether it is along a scar, whatever. Be very concerned about it and take it seriously. So some common presentations that you'll see are cellulitis, right? So that's hot and red, and indurated. If you learn nothing else today, please learn the definition of induration, because this is so important for making the diagnosis of cellulitis. And also, it's the thing that we're looking for when we do the PPD, right? We don't care about for the PPD that is, we don't care about the swelling, we don't care how big, well, we do care how big the rash is, we don't care about what color it becomes. What we care about is induration. And induration is hardening of that lesion. That's that inflammatory process that we talk about all the time in pathophysiology, right? So it's firm to the touch, and that's because of all the edema and all the other schmutz going on in there. The pus formation and the macrophage infiltration and the neutrophils and the T cells and all that other jazz that's going in there makes it indurated. Learn that term, induration. Induration is what you're concerned about, or what is diagnostic of cellulitis and other skin infections like that. Okay? I see the puppy is under control now. She listened to what I said, thank God. This is a great example of what happens when you have topical medications that have photosensitivity associated with them. So whether it's Retin A, or actually you can have oral medications that give you photosensitivity as well. You don't get a super beautiful tan from that. You're not more likely to get a great look from it. You're more likely to get a crappy look from it. So this is a woman who was on some kind of medicine. I forget what she was on. She was on some kind of medication that gave her photosensitivity. And this is an image from where her hair covered, right? So you can see that her hair covers this part very nicely. And then there's a little part here. So she has that area that got too much sun. And her nose is covered by her sunglasses here. And then the rest of her face got this photosensitive reaction. So that's what people with photosensitivity from drugs can be expected to have. These are nodules that were shown in this gentleman. He developed these nodules all over his body. They were painless, and it was just adipose tissue that had been incorrectly distributed. I don't know how else to explain it, but these nodules like this are things that you may see, hopefully not this dramatic, but how would you describe this? Where would you send the patient? What would you do about it? Well, you would look at the patient, evaluate the lesions, examine them for how firm they are, whether they're mobile, how long has it happened, how long have you noticed the problem? Has it gotten worse? Is it getting better? Or can you do anything to improve it? All that old carts stuff. And then as you're examining them, you can see if they're painful, again, if they're mobile or whether they're stationary. Those things are important to put in the consult request to dermatology or whoever you're sending them to. So I just showed you that as a dramatic example of something that you'll periodically see and go, whoa, I have no idea what this is. How do you proceed from there? Well, you just gather the same information. You don't have to come up with a diagnosis, right? You just have to be able to describe it to somebody who knows better. This is a very, very typical presentation for somebody with chronic venous insufficiency. So you can see they're obese, right? Morbidly obese. And that obesity pushes down on the belly, prevents the blood from returning back to the heart. And where does that blood end up? Well, it ends up in the veins. And how does it end up there? Well, it ends up with the veins getting bigger and bigger. The valves in the veins continue to stretch downward, and that causes the swelling in the lower extremities. But in this case, there's even more than that, because that venous insufficiency has caused this awful looking crusting, well, I guess it's not officially crusting, right? How would you describe this? This rash that's raised and scaly. This is a result of chronic venous insufficiency in the very extreme sense. All this hyperkeratosis, or all this raised stuff, is hyperkeratosis. And that is as a result of the massive, continuous venous pooling that happens in the lower extremities. Venous ulcers can form. Remember that we tend to see venous ulcers in the medial or the lateral aspects of the legs. But there's also a superimposed infection on this leg, and he needed a little bit of antibiotic. The treatment for this, obviously, other than weight loss, which is, that's just a very difficult thing in somebody who is so morbidly obese. They're not going to get to where you want without bypass or without bariatric surgery. In fact, do you know the statistics? The last I heard, the chance of you losing weight when you're morbidly obese and keeping it off is about 1%. This was made famous by the Biggest Loser competition, where they looked at these patients, or they looked at these participants years after they participated on the show. Every single one of them had regained their weight. Even though many of them tried to keep it up, their metabolic condition caused them to regain the weight. It's a very complicated disease. 1% chance of success. That is minuscule. Don't beat your patients up because they're fat, all right? Coming from a fat guy. The second thing of this is that if you give them the option of bypass surgery or other bariatric means, I guess they do the sleeve stuff now more than anything, that is associated with a 70 to 80% success rate. 70 to 80%. Why would you not do that? Why would you not, right? It works. It is successful, and that's my speech about bariatric surgery. Okay, good. Moving on. This is a fascinating problem. Who knows what this problem is? Notice that it is right down the middle. Right down the middle. There's nothing that crosses that central line, that midline. It's all located over here. Also notice that it doesn't go down past the eyelid, right? A little bit down here, but what else may leak down from there? Well, maybe some neurons that get sort of out of control, and instead of just growing along this dermatome, they fall down here a little bit too. Well, guess what this is? This is characteristic of shingles. This is a pretty severe case. Of course, this is very painful to the patient, has this crusting characteristic to it. But the important thing is, when you see a rash that stops at the midline, you can just assume that that is shingles until proven otherwise, all right? Because there's very little, I don't know of any other thing that stops at the midline and only follows the dermatome other than shingles. So I think that's an interesting picture for illustrative purposes. This is a cord. I don't know if you've ever seen a cord before, but this is a cord that is present in this baby, and it's an infection, and that infection goes right up the length of the vein there. This came after this child was immunized against varicella. So this is the kind of thing that you're looking for on your physical exam. This is a pattern that is unmistakable, right? You can see that it follows a particular course in the body. It doesn't go up and loop around and go back down and, go in a crazy manner that we can't explain. This follows a path, and so that's a good thing to be able to see. And that can give you hints about what the problem is. So this is a tinea infection. And it's tinea. It was an atypical organism that they found, but this is the pattern that you see with tibia. It's the round area with a central clear spot. The central clear spot is not so clear in this case, though, is it? And that's why this rash is atypical and why it's shown in the New England Journal, because it doesn't have that central clear spot. These are urticaria. I told you that we would see urticaria again. These are urticaria spots, and this you see with certain areas of or certain allergic reactions. This also has a central clearing. It's not completely clear like you would expect at a tinea or a ringworm, but there's still some rash here. It's just not as pronounced as it is around the outside. Okay. A couple things not to miss. This one, take a good look. Notice this area on the trunk and the area here inside the mouth. This patient also had this blanched area on the face, neck, trunk, and arm. Had some posterior cervical adenopathy, right? Don't forget to check with that one. This is actually rubella. This patient had rubella, and this is one of those rashes that's characteristic. I don't know anything about rubella, but this is a characteristic rash. And when you see these characteristic rashes, they should be noted. You should remember this kind of thing forever. I think I told you when I was a kid, I had measles one time, and it's weird because I was vaccinated, or so I thought. Turns out that in early 1970s, the MMR didn't really work very well. It didn't give the same benefit that it did in later years. So I had been partially immunized, and I had this weird rash that was not classic for measles, and my pediatrician was 127 years old, and I asked my mom, why did you send me to a pediatrician who was like so crazy old? I don't understand. She said, you know why? Because he's seen it all. And that's the point I'm trying to communicate. There is no substitute for experience. So you're not going to be an expert at recognizing these lesions and rashes and things when you first start. And you're not going to be an expert in 5 years, but you're going to stick to it. You're going to learn every time. You're going to remember these things, and soon you'll develop pattern recognition. And when you see a rash like this, it's not going to fit into any of those patterns. And then you can look and say, you know what, this is a weird thing. And now I can look it up, and I know exactly where to start looking because I know all the stuff it's not. Now I need to see what else I could be missing. This characteristic rash looks like it might be a childhood illness, and so start with that. All right, so don't get freaked out. Nobody knows everything when they first start. Physicians don't know everything when they first start either. They have a lot more training and experience coming into the job than what you're going to have. But you know, in 5 years, you're going to have caught up to most physicians in primary care and be able to handle a lot of what you see. This is another interesting childhood illness. This is diphtheria. And you can notice that there's swollen glands here, or swollen nodes, I should say, and this characteristic rash in the throat. This patient was never vaccinated. She's from a third world country and only got a couple of the initial vaccines as a child. This one I hope you never see. This is caused by an organism called Treponema pallidum. Anybody know what that is? This is the rash of syphilis. This is the rash of syphilis. So know it. Don't forget it. Very characteristic look to it. Tertiary syphilis, ladies and gentlemen. All right. When you're evaluating a bedbound patient, looking at their skin, so all you acute care NPs out there, make sure that you look everywhere. Don't be that person who doesn't bother to look at the butt. There's all sorts of stories about patients, being transferred downstairs to the operating room. They get ready to put them on the table. The patient's been in the hospital for a week or whatever, and they put them on the table and they see a giant sacral decube. Well, why is the operating room the first place that was discovered? Well, because nobody else is bothering to roll the patient over and look. So you have to make sure that you're doing that. You're committing malpractice if you don't follow through, and if you cheat when you're examining these patients. Make sure that you do it. It only takes a couple of seconds, and it may take another set of hands to help you, but do it. It's really important, especially for hospitalized patients where a major complication of hospitalization is skin breakdown. Okay? All right, so findings of the nails. The anatomy of the nails. We've been talking about it, right? This is how you look for clubbing. Oh, did I say this is Schwann's window? That's stupid. This is Shamroth's window. I don't know why I was thinking Schwann's window. Maybe because the Schwann's truck was outside trying to bring food here. Don't ever order Schwann's, because once they come, they never stop coming. My wife and I take turns running away from them when they come. So this is clubbing. I rarely see clubbing, but you can see it a lot in congenital heart disease. And in third world countries, you see it a ton. Paronychia. This is, I don't even know what paronychia is, but I do remember that this is what it looks like. How's that? Onychocryptosis. This is ingrown toenails. It looks so painful. I don't even want to look anymore. And then Onychomycosis. This is the fungal infection of the nail. This, by the way, is only treatable with oral antifungal agents. It's gross, right? All right, so that's the skin, hair, nails, all that. Let's talk about the head and neck exam. You know the anatomy. I'm not going to bother with that part. Symptoms are listed here. These are the things that bring patients into the office, or the things that we want to investigate when we have the patient in front of us. So you start with the inspection and then the palpation, of course. I think everybody's been doing a pretty good job with that. With the mouth and pharynx, there's a lot to look at here, right? You got to look at the lips. Are there any ulcerations, any lumps, any cracking, scaliness, etc.? Then you have to look at the oral mucosa. You can't look at all the oral mucosa without a tongue blade. So make sure that you have a tongue blade and a piece of gauze. You have to use that tongue blade to move lips and cheeks and everything out of the way so that you can visualize all this stuff, right? It's important. Use the gauze piece to pull the tongue away side to side. Look at the entire thing. Look at the roof of the mouth. Look at the tongue and under the tongue to look at the floor of the mouth. And then the pharynx. There's lots of stuff to see in there. I'm going to show you some pictures here that illustrate why you can't just do a drive-through evaluation of the mouth and pharynx, because some of these things are pretty tough to pick out. So a couple of the common abnormalities that we see are this cheilitis, this cracking that some people get around the corners of their mouth. I think we all get it. I've had it before. It's annoying and all that. And then there's the herpes infection, cold sores. This is an example of angioedema. I'll show you some more dramatic ones, but just this isolated swelling of the lip. But it can also involve the tongue and the soft tissue in the pharynx as well. This is hereditary hemorrhagic telangiectasia. And this can sometimes be associated with other bleeding throughout the GI tract. So this is an important finding, although pretty rare, right? So this is an example of a patient who had angioedema, and this, you will never believe this. This happened over a 6-hour period. So this is the patient at the beginning. This is the patient at the end, at the peak of her 6-hour interval. So this is a very extreme case of angioedema, and there's lots of reasons that you can have angioedema. It can happen with horrible causes such as lymphoma. It can be associated with lymphoma, but by and large, and by far, I think, the most common etiology is medications, right? And what is the classic medicine class that does this? ACE inhibitors, right? So ACE inhibitors can be associated with this even years after they've been taking it. They can be on this for years. I had a patient who was on a ACE inhibitor for literally, I saw her for 9 years before I saw her in the emergency room with angioedema. It was rapidly closing her airway. She got trached. We stopped the ACE inhibitor. Literally 2 days later, we took out the trach, and she was fine. And she was actually fine the next day after it wore off. When you see this from a medicine, you stop the medicine and it gets better. It goes away on its own. It can also be associated with ARB use. I would tell you what I've read if I believed it. And what I've read is that ARBs are so unlikely to cause angioedema that you should look for some other reason. I would believe that if I hadn't had angioedema from an ARB. And it's the real thing. I didn't have this dramatic a thing. I got a little lip swelling and it got better when I stopped it. And then, of course, I didn't believe that it was the ARB. So what did I do? I did the Irish stress test, and I took the ARB again. And guess what? I had more swelling, and then I sort of proved it, right? So that is angioedema. But check this out. This is another case of angioedema. This is from an ACE inhibitor in this case. And here again, this patient ended up getting intubated or trached, or I forget how they did his airway. I think he was trached. And the next day he was fine because they stopped the ACE inhibitor, and it went away. But that is dramatic angioedema, is it not? Ugh, so uncomfortable. So we've looked at these benign findings of the tongue before. You can see this geographic tongue where it looks like there's a map drawn on it. This is the fissured tongue. This is the hairy tongue, black hairy tongue, which is just from these elongated papillae on the tongue. All benign findings. This is the Mallampati Classification. You remember that anesthesia uses this when they're evaluating somebody's risk for intubation. Class 1 is where you can look in there and you can almost see their cords without even using a laryngoscope. And then class 4 is where all you can see is the hard palate. There ain't nothing else. You can't even see the uvula and the back of the soft palate. So this classification system useful in acute care and something you want to take note of when you're about to intubate somebody for show. Different images of the tonsils. So these are enlarged but benign tonsils. There's no exudate coming out of them. I think that white spot there that you see is just a reflection from the camera light. But these are, a lot of people have tonsils that look like this. They're huge. They almost touch in the back. When I was in grad school, like you guys are, I had, in my first year of grad school, I had 7 throat infections. My tonsils look like this all the time. And I think one more infection, I got a free set of steak knives. But thankfully, I never had another one. I don't know. I don't know what happened. I went to see ENT. They said, yeah, we should take them out. And then I never had another one. So it was good. There's a rash that you can see on this image here. See this little macular rash that's on the pillars back here. That's all I can tell you. I just wanted to show you that. This is the classic exudative tonsillitis that you can see, this like Z shape here. That's just exudate coming out of the tonsils. A couple of things. One thing is this marginal gingivitis, and this is where you see this inflamed tissue here in the gums. It's not beet red or anything like that. It's not enormous, but it's a little oversized, a little generous, and doesn't look healthy, right? It doesn't look like the rest of the gums. So this is gingivitis. And then there's gingival hyperplasia, and you know that this can be associated with certain medicines like Dilantin, and classically the dihydropyridine calcium channel blockers. We saw it a ton with Procardia or nifedipine. And then when amlodipine came out, or Norvasc, we sort of stopped seeing this problem as much. But this is a potential problem. Again, blacks tend to have more severe gingival hyperplasia when they have this reaction than non-dark-skinned people. Classic candidiasis, you've seen it a time or two, I'm sure. All right, so this is the leukoplakia that I talked about. This is leukoplakia. I can't really tell where we are. This is the lower teeth. This is the upper teeth. This is the mandibular, the angle of the mandible. And then the leukoplakia is this white stuff. It looks like it's just a plaque that lays on top of the normal tissue. That's dramatic. That's easy to see. You can spot that without, in the first 1 second of looking at the mouth. But look at this. This is why you have to lift the tongue. This is on the underside of the tongue. Notice that, it's not that standoutish, right? This, you really need to take your time and look carefully and make sure that you don't see any of this business going on. Because this is the kind of thing that you can easily miss. And that could be a disaster because this is about to turn into cancer, as I understand it. I don't know, maybe I'm wrong. All right. This is someone's lower lip, this crusting that you have on here, along with the inflammatory look to it with the induration that you have. Oh, look, we got to use the word induration. This induration that you see down deeper, that was very concerning and turned out to be carcinoma of the lip, apparently. Here's another picture of some leukoplakia. This does stand out pretty well, but I've seen some pictures of leukoplakia that, dude, like, how did you even see that? That is something I would have totally missed. Again, this is pretty easy to look at and see, at least in this picture. But when you're examining these patients, you have to be very, very careful to see that. So, deeply pigmented lesion, this time in the mouth. Anytime you see a deeply pigmented lesion that doesn't belong there, that's new, that they weren't born with, what are you going to think? Turns out this is melanoma as well. So just keep in mind, you got to take a good hard look inside the mouth. You don't want to miss something like that. Okay? Hopefully I've scared you a little bit into slowing down your exam and making sure that you're thorough in doing it. Okay? So the nose and sinuses, I think we all get this. I'm not going to spend much time on that. This is the view, though, that you see. Remember, we talked last night about the number of turbinates that you have, 3. The number of turbinates that you see, 2. So you can see the inferior turbinate and a little bit of the middle turbinate. You don't see the whole thing there, but you certainly don't see the third turbinate at all. Palpation of the sinuses. Again, the frontal sinuses right here, maxillary sinuses right here. Doesn't take much pressure if you got a sinus headache to cause you to go through the roof on that exam. And then the neck, we're going to look for symmetry, masses, scars. Remember that scar thing is a big thing. We're going to look at the nodes. We want to look at the trachea position and alignment, you acute care types and trauma types. You want to look to see if there's tracheal deviation. If the trachea deviates to one side, it's either because there's volume loss on the ipsilateral side that it's moving toward, or there's excess volume, like a pneumothorax or a hemothorax or whatever, that's pushing all those structures over to the contralateral side. All right, so be on the lookout for trachea position and alignment. And then the thyroid gland, of course, and we're going to look for all of these nodes: preauricular, post, occipital, tonsillar, submandibular, submental, superficial cervical, posterior cervical, deep cervical chain, and then the supraclavicular, right? Those are all the ones that you want to keep in mind and do it well. This is the anatomy. This is important, particularly when we're putting in a central line in the internal jugular, but it's also important that you see that the sternocleidomastoid covers up all the good stuff. It covers up the internal jugular, which is shown right here. The vein that you see on the outside here, on the very lateral portion of the neck, that's actually the external jugular, and that doesn't help you. That doesn't tell us anything when we see the external jugular. We want to see the internal jugular, and we can see that once it once it appears again from behind the sternocleidomastoid. Notice it runs right alongside the carotid artery. And so if you are like all of the undergraduate nursing students, I'm sure you're not, but and you want to feel your carotid pulse over here, you're not going to feel it there because your carotid ain't there. So to feel your carotid, you want to go from your neck and go just over so that you can still feel the trachea, but just to the side of the trachea, right beside the trachea, is where you're going to feel the carotid pulse. So your carotid is actually right next to your trachea, and you should be able to feel it right there. One at a time, not both, right? All right. And here are the nodes. Remember, I want you to memorize these, know exactly where they are, be diligent and careful in looking for each of those nodes. Don't just go through quickly and say you don't have any adenopathy, because there could be serious things associated with that adenopathy. If you miss it, you'll be in trouble. All right, and then the thyroid gland. I don't have much to offer you here. I think most people looked at the book enough to understand that this is a hard thing to see. If you want to be able to palpate this isthmus, you should give the patient a drink of water, and swallowing will make that isthmus more prevalent during the swallowing process. All right, I have a couple of other interesting findings to show you here. One of them is this one. This is the classic blue man syndrome from amiodarone. And we used to see this a ton when we were using amiodarone at high doses for extended periods of time. Amiodarone does not stay in the blood very long. It gets leached up by the tissues in the body. And one of the side effects of that is that it can make your skin blue. So you see some slight bluish discoloration when we use amiodarone for treatment of atrial fibrillation, but usually it's at such low doses that we don't see this complication. Again, we used to see this a lot more when we had patients who were getting 800 milligrams a day or even 1600 milligrams a day, but usually 800 milligrams a day for ventricular arrhythmias. This is a very interesting thing. I just thought this was fascinating because I'd never noticed it before. These darkened areas here on the thighs of this patient. I will tell you that as a hint, this patient had COPD and had great difficulty breathing. And when she had trouble breathing, which was a lot of the time, she would lean forward and put her arms on her legs like this and rest just so that she could expand her thorax more. And that's what that's from. That's just a result of having had COPD for so long and using that as a mechanism to be able to breathe. This is fascinating as well. We talk about the physical findings associated with bacteria or with endocarditis, but we hardly ever believe them, and we rarely, if ever, see them so dramatically here. These are splinter hemorrhages that you see in this patient's fingertips. We're lucky if we get 1 or 2 splinter hemorrhages that we can see in somebody with endocarditis. It used to be a very telltale sign back before we caught endocarditis so early. But now we're more likely to see no physical findings that help us, and that's why the echo is so important. But splinter hemorrhages associated with endocarditis, and the image here shows some areas of the kidney that are not getting enough blood supply. Kidney and the spleen. These are the kidneys. This is the spleen that are getting infarcted. So these are those Lindsay nails that you learn about. So there's this nice white area, and then there's this pinkish area here on all the nails. And this is associated with chronic kidney disease called Lindsay nails. This is neurofibromatosis. This is another thing that goes along the dermatome. This is not an inflammatory process. It's not painful or anything like that. This is the neurofibromatosis, same disease as Elephant Man, if you know that story. So those are generally benign. This is fascinating. This woman, this was published in the New England Journal too. This woman had she had a stricture in her stomach, and she was unable to eat for an extended period of time, for like 6 months. And she also had gingival bleeding, and she had this very characteristic rash. This is the rash of scurvy. And the reason she had scurvy was because she had such problem with her stomach and was unable to swallow any food. And so she was quite emaciated and had clinical scurvy. Take a look at this. This is an image of retinal trauma or retinal hemorrhage from trauma. This patient got hit in the eye with a tennis ball and had these classic findings. But this is a collection of blood in the retina here. And so this person needed to go to ophthalmology, and they operated on him, and he did fine. But that's what you're looking at there. All right, I did this just so I could make fun of myself. Notice the sclera here are not white. I get it. Remember I told you that sclera are always white. It's the conjunctiva that changes colors. Well, in this case, this patient was on a medicine, minocycline, that built up, and the levels ended up residing in the eye, and that makes his sclera appear bluish. Now, how that happened, I don't know, because the sclera are avascular. So how did that even get there? I don't know. I don't understand that. Here's another reason to do a good, thorough eye exam. Guess what this is? That's right, squamous cell carcinoma of the conjunctiva. Not the sclera, the conjunctiva, right? So make sure that you're doing a good, thorough exam so you don't miss something like that. You don't want to be the nurse practitioner who is famous in the community because the patient went to see you with a tumor growing in their eye and you didn't pick it up. This is kind of gross and cool at the same time. This is a tick that was attached to the patient's tympanic membrane. Some 9-year-old kid was at camp and found this ringing and buzzing in his ear, and that's what the cause was. This patient has Ludwig's angina. I don't know if you remember what Ludwig's angina is, but this is a severe oral infection that, or in the pharynx somewhere, that causes such a great amount of swelling and, by the way, submental adenopathy and submandibular adenopathy. You can actually see the adenopathy here in this fullness of, below his jaw. Quiet. Shh. So he got antibiotics and got surgical treatment and protected his airway, and he ended up doing fine. This is one of the physical findings associated with pernicious anemia. And so pernicious anemia, right, is a B12 deficit. And is it B12 or folate? I can't remember. Maybe it's folate. But in any case, this is the look of pernicious anemia. Notice this normal tongue after the pernicious anemia was addressed. And this is the smooth tongue with very few visible papilla. This is a tongue ulceration here in the middle from CMV. This is a very characteristic lesion. You would certainly be able to pick this up on physical exam even if you weren't looking too carefully. This one's interesting. This patient had been, this is a 60-year-old patient who had been treated for colon cancer, I forget how many years before. And then she noticed this lesion in her mouth, and it turns out it was metastatic colon cancer. And then finally, tonsillar cancer. So take a look at this. Look how hard it is to see this. You see this? It's almost impossible to see. Look at that. You have to look at a lot of normals in order for this to jump out at you. So look in everybody's throat. Every time you see friends now, instead of bumping elbows with them or touching hands or whatever, say, "Can I look in your mouth?" and then do that. I think you'll become a better nurse practitioner as a result. All right. Hope that was helpful to you. Take care.